Hi there, and good evening. Welcome to the Jim Bohannon Show from Westwood One Radio. We're at 1-866-50-JIMBO, 1-866-505-4626. Online, find us at JimBohannonShow.com. You can follow me on Twitter at Jimbo Talks. We're joined in this portion of the program by Paul Seegert. He's managing partner at PCS Advisors, Financial Advisors. Good evening, Paul.
Good evening. Glad to be with you.
I'm going to be talking about something that has not become a major headline, probably should have, because it affects a lot of people very directly, and that is, I gather, there is a crisis at rural hospitals. Would that be safe to say?
There is. It's a long-term trend. In the years of 2000 to 2009, we lost 74 of those hospitals, and then in 2010 to 2021, we lost another 136, 19 of those in 2020. And it's a dire situation, and they're facing a funding cliff, you could call it, in federal funding dollars that may go away as soon as the end of this month, to the tune of about $600 million in funding.
And where is that money coming from?
There are a couple of programs that exist to account for the fact that reimbursements from government payers often are not enough to cover the total cost of care, which can work out okay if you're in an urban environment and you have lots of folks showing up with commercial plans, employer plans, and so on. But in these more rural areas, the majority of their patients are going to tend to be government payers or uninsured, much higher rates of uninsured in those areas. So the government came up with a couple of programs, Medicare-dependent hospital and enhanced low-volume adjustment programs, which are just a couple of names that basically meant the same thing. If you are at risk of not being able to function financially because most of the people that show up are pulling a government payer card out of their wallet, this was meant to account for that and provide extra funding to those.
Would it be safe to say that most people who use the services of rural hospitals tend to be older and sicker?
Yeah, that's absolutely correct. It's an older population. They do tend to be sicker, and you have about 26% of them that tend to be uninsured, which is much higher than what you'd see in other parts of the country.
So, in effect, the method we have for reimbursing health care in this country, you tell me if this is the right word, discriminates against rural areas?
I would say that is true. In a couple of ways, that's true. And we also have this reality that even in urban environments, you have government payers. When you use the word subsidy, most people think that you're going to start talking about the government, but actually I look at it in a little bit of a different way in this particular topic, because the government, Medicare, Medicaid, when a government payer shows up at a facility, both urban and rural, those facilities don't get a reimbursement that's enough to cover the costs of most of those procedures that they provide. So they may need 120 to 140% of what the government pays them to treat that patient. They tolerate that in the urban environment because they know that somebody's going to show up with an employer plan. And in fact, Rand Corporation came out with a study just a couple of weeks ago that showed that nationwide the average is, if you show up and you pull an employer card out of your wallet, that hospital is going to bill your plan 224% of what the government payer would pay for the same procedure at the same facility. So that has been sustainable in urban environments, but definitely not in rural environments where less and less, as employer plan enrollment overall has declined, it's affected those areas more sharply.
All right, 1-866-50-JIMBO, 1-866-505-4626. Are we talking here about a lack of substitute services? Or, for example, clinics being set up, or are individual doctors' offices being set up? In other words, has there been any substitute for the disappearance of rural hospitals?
Not a good substitute. What we're finding is that you'll have people in certain rural areas that maybe used to have the ability to drive 20 minutes to have a child that now have to go another county over. And that county is picking up all the patient load, or a lot of the patient load, from the facility that closed. Then you actually have another, I think, looming crisis in the rural areas of a shortage of primary care physicians. You have 10% of physicians in this country that choose to live in rural areas where 20% of the population lives. And we're already also dealing with a kind of a growing shortage of primary care.
Wasn't there once a program that offered to forgive portions of medical school expenses for people for doctors who moved to underserved areas?
Yeah, those programs do still exist.
But they don't work?
Well, not as well as they were intended to, because I think what we've created is a system where most of the folks that go to medical school want to end up in a specialty where bigger earnings can occur. They're much higher compensated professions. So we struggle with that.
But goodness knows we need another dozen plastic surgeons as opposed to primary care in a small town. Yes, there was sarcasm involved there. Let's get a call from GW in Galesburg, Illinois. Good evening.
Good evening, sir. How are you?
Fine, thank you. What's on your mind?
Well, I live in a very rural community. I live in Galesburg, Illinois. We had 2 hospitals. One of them recently closed. The problem I have is being a veteran, because the Veterans Administration has said that veterans that have to travel over 60 miles are eligible for community care. I either can't get community care, or the care is delayed so long because the doctors either won't take the veterans' pay, or they're just simply so busy that it may take me 2 or 3 months to get an appointment to be seen or to receive any kind of care.
Let me get something straight here, GW. You are a veteran, and you get some kind of voucher for the government-paid medical care, but the local doctors won't accept that?
Yeah, here's what happens, Jim.
Okay.
The veterans have said that if you live over, in a case like me...
By the veterans, you mean the Veterans Administration?
Yes, sir.
Okay, go ahead.
They have a thing called community care. If I live over 60 miles from where the veterans themselves can provide me care, then I'm eligible for community care.
That is to say, the Veterans Administration. I guess it's critical to make the distinction between veterans and Veterans Administration. And I'm familiar with the idea. It's supposed to make it easier for veterans to get medical care. I mean, if they've got to drive 300 miles to get medical care, the idea was you could get it in your own community. And you're saying that isn't working?
No, sir. I live 125 miles from the Iowa City Veterans Hospital, where I can get care for things like neurosurgery, orthopedics, heart. I have a heart condition.
Right.
So they try to put that in my community.
Right.
Many doctors will not accept the amount that the VA pays, so they just simply say no. The ones that do accept it, they're so overloaded that the original plan was that if I couldn't get care at the VA within 30 days, I would get care elsewhere. It often takes me 60, 90 days because I have to get an approval from an insurance company called Optima. That's the VA's community care insurance company. I get referred to care. They receive that referral. They have to process it, contact me back and say, now we give you approval. That often takes 30 days. Then they, not me, they find somebody in the area that will accept what they will pay. And quite often, that's still 60, 70, 80 miles away from me. And then,
well, we got the general outline of the problem. Paul Seegert, does GW's story sound familiar?
It surely does. And I think it highlights a real challenge we have in our system overall, which is that the government, as a payer, is not paying their fair share. And you cannot simply rely on the goodwill of a provider to work at a loss. And that's essentially what they're asking them to do. Which,
by the same token, does it make sense to build, say, 100 or 200 new VA hospitals to serve a small and shrinking community? I mean, the general idea was a great idea. But I'm not sure what the answer is. The answer is not to build a new VA hospital in a community where there may be only a handful of veterans, I wouldn't think.
Right. No, I agree. That's not a reasonable solution.
Then what is the answer?
The answer, I think, is for those government payers, the VA in this case, to increase what they compensate these providers so that they can actually afford to provide care.
Is that within their power, or does Congress have to go along?
Well, I think we'd have to get the involvement of Congress and to fund the program more, which is unfortunate and not terribly efficient, of course.
Yeah. Well, good luck to you, GW. I really mean that. We'll be back in a moment. Jim Bohannon Show at 1-866-50-JIMBO, 1-866-505-4626. Looking for adequate medical care in a rural setting? Well, good luck. Our guest is Paul Seegert, managing partner at PCS Advisors, the financial consulting firm. And here is Sue in Schwenksville, Pennsylvania. Good evening.
Good evening. You know, this is a very interesting topic to me. These days, of course, I live outside of Philadelphia, but some years back, I would say 20, maybe 25 years ago, I lived in a very rural county in Ohio, Vinton County. It's I would consider it to be Appalachian, Ohio. And when I first moved there was no doctor in the entire county, let alone hospital or anything like that. There was a physician's assistant who was acting as a physician, you know, for that entire county. Now, it's a very low population in that county, and, you know, it's a poor area. Now, once I was living there, they did finally attract a doctor to the area, but there was just one. And then, and I think she stayed. I believe she still practices there, but they did attract some of these physicians that you talked about earlier, where they had some of their medical school expenses paid if they put in, say, 2 years or whatever in a rural community. But they did not stay because, and to quote the guy, this doctor who didn't stay, he said, "I'm not practicing medicine. People here don't even know basic nutrition. There's really nothing to keep the doctors there because the population is very, you know, there's less education there. There's nothing there for them as far as any kind of, you know, things that you would find in a regular city." And I believe it hasn't changed appreciably. When I was living there, I had a bad Pap test, and I had to go to Columbus, Ohio, which was an hour and a half away to really get care for that. So the nearest hospital to there's in Athens County, which is where OU is. And that's
Ohio University, right?
Yep. Yeah.
Okay. All right.
That's a hospital 30 miles away. So I don't know that it's changed any. And I think one of the reasons is doctors are not to those areas. But your guests would know better.
Yeah. Well, I gather that it's a continuation of a trend, Paul.
It is. I would say it's changed in that it's gotten worse. It, maybe not specifically in that county, but when we look across the whole country into these areas, you see that we have less than 2,000 of these facilities left. And when you see that we lost 19 in just 2020, it's pretty alarming.
Well, it certainly does seem to be. Yeah. Again. Well, I'll ask you another question here in a moment. Right now, let's go to Gil in Manila, the Philippines. Hello.
Hello, Jimbo. I just wanted to make one point about
Manila, the Philippines.
Your topic, about your topic there in the States. Of course, I lived there for a long time. But one of the big problems with hospitals, big and small, is when all of these new people who have come from other countries without the benefit of an immigration status, when they get sick, they go to the emergency room.
Exactly, that's their primary care. And that people, it's too bad they don't itemize property tax bills in this country, or they'd find out just how much of the local taxes they pay are going to pay for people in this country illegally in schools and the people illegally in this country in emergency room care. But please continue.
Yeah, and that was the situation I wanted to point out. I've noticed that over the years, and as we get more and more folks in the States without the benefit of immigration status, that's probably going to be more of a problem. And one side thing, you know, I just dodged a typhoon that came through here yesterday, and we came through it very well. North of us, they didn't do so well, but that's life.
Well, I'm glad you came out of it okay, Gil. Thank you, sir. I suppose the influx of people in this country illegally has its impact, Paul. Although I'm not sure that would be principally a rural phenomenon, would it?
No, I think it's all hospitals that are affected by it, and you know, maybe it just gets lumped in with kind of the uninsured population that shows up and gets care at the ER as their primary care, and the whole industry is in rough shape at this moment. 53% are expected to post a loss in 2022, including urban facilities. And that
of course, is not the function of an emergency room, and that needs to be changed. Paul in Lansing, Michigan. Good evening.
Good evening, Jimbo. Hey, I don't want to
come down on you guys or make you feel like I'm picking on you or I'm nitpicking.
Just go ahead and ask your question. We're grown-ups. We can take it.
It's not so much a question as a statement of observation.
Okay.
As I hear you say VA and say Veterans Administration, the VA is the Veterans Affairs. Then there's the VHA, which is the Veterans Health Administration. And then as I scroll through, I'm a veteran, you're a veteran, he's a veteran, we all scream for veterans. I've made it like a point to stay away from them since like the 40 years.
Well, I've never used them myself. Yeah.
I mean, I've been there 3 or 4 times. It's just, so they make it so difficult. They make it complicated to even, I mean, everything's done online now. And if you don't know what you're actually looking for and where you should be going to online, you can go down a rabbit hole that can take
exactly
a long way around.
And nobody's there to offer you advice on how to navigate that. All right, stay on the line since we're coming up on a break that doesn't move, and we'll get the response from Paul Seegert, managing partner at PCS Advisors, in just a moment. Welcome back to the Jim Bohannon Show at 1-866-50-JIMBO, 1-866-505-4626 with our guest Paul Seegert, managing partner with PCS Advisors, the financial consulting firm. And we're talking about the shutdown of rural hospitals and the general lack of adequate health care in rural settings in this country. Any proposed solutions, Paul?
Well, I think in part we have to, it's pretty darn urgent right now that we look at these 2 funding mechanisms for these hospitals that help them deal with the fact that normal reimbursement rates from government payers are simply not enough to cover the cost of services. Those need to get extended. And then we need to look at the system overall in terms of reimbursements and how we pay and make it more equitable.
Since doing that every 4, 5, 10 years or so, you never quite keep up with things. Maybe some kind of COLA adjustment, cost of living adjustment, needs to be included.
I think you make a really great point, because when you look at the way payers negotiate with providers, with hospitals and so on, they'll get them into multi-year agreements. And that's why 53% of hospitals are expecting to post a loss this year, because they've got this, their compensation rates are static. And when you think of what's happened in our economy in the last 24 months, if they signed an agreement around their reimbursement rates 25 months ago or 23 months ago, they are not getting enough to cover the cost of things today. When you look at labor costs that have skyrocketed in an industry that already was suffering from staffing shortages, and cost of all other things, with just general and broad inflation impacting this industry, they're in a very tough spot, and it has to do with that frequency with which they renegotiate those reimbursements, like you pointed out.
May I assume it is safe to say that the last people on the planet to really care about the quality of health care provided would be people who run the healthcare system in this country, or is that overly cynical on my part?
It's definitely a business. That's for sure, and I think it's easy to find things that would confirm at least some cynical feelings about it. It actually ties into our conversation about rural health facilities. Urban healthcare relies on these commercial payers to make up the gap, and there are some commercial payers in rural areas, not nearly as many, but the insurance companies that represent these employer plans in those areas, or private plans, individual plans, whatever, they can go into these rural areas and say, look, it's time for our every couple of year negotiation, and we're simply going to offer you this very low reimbursement rate. Take it or leave it.
So instead of the general public chipping in through their tax dollars to say these are veterans and we owe them something, it's people who've got health insurance already, like me, for example,
right,
who are carrying the load by ourselves. Is that right?
Yeah, it really is. Our premiums go up significantly year over year, 6, 8, 10%.
That's not a fair system. I'm sorry. I'm a firm believer in support for veterans. I am a veteran, but the idea that one segment of the population does all of the support, no.
Totally agree. And at this very moment, Medicare is looking to reduce their reimbursement rate that already puts these hospitals in a precarious position. Another 4% by the end of the year. They want to reduce their compensation to these facilities.
Okay, here's Mark in Ravenna, Ohio. Good evening.
Hey, good evening. We have med centers. They're building them everywhere, and within a 10-mile radius of a local hospital here.
When you refer to a med center, Mark, I'm not sure quite what that is. Is that like a clinic?
Like an urgent care in front of my employer right now. They just built a brand new urgent care. That's 4 miles from where I'm at. I guess I'm trying to understand what an urgent care is. Is that like a clinic? A clinic, right. They have several. Okay. It's like an emergency clinic, but you usually are treated just by an emergency physician if you don't have your own physician, and that's what a lot of these local people are doing.
So in other words, you may have something that's not an emergency at all, but you don't have any place else to go to get health care, so you clog up the emergency care center with your own particular needs. Paul Seegert?
Yeah, we're seeing a lot of, because of the shortage in primary care, you have these urgent care facilities popping up, and they are becoming a kind of the de facto primary care provider. And then you'll also see that they're popping up in markets with different brands. So one might be affiliated with one hospital group, one might be in your area, but affiliated with a bigger hospital that's a little bit outside your area, because they know if they control primary care, they control where you likely go next, where the real money gets made, specialty services, surgeries, etc.
Okay, although I would dare say in many cases, from some of these patients, there is no real money to be made, right? They can't afford basic medical care.
Visit. Yeah, not on those visits for sure.
All right. Johan in Brooklyn, New York. Good evening.
Yeah. Listen, you have the urgent care. Man say urgent care. Sure. In Brooklyn, every street, almost every street, is the urgent care. I go to urgent care. I tell them, look, I have pain. I have pain in my leg. So they see me, they touch, they give medicine. Say, oh, will this medicine help you? Yeah, sure. And then pain still comes. So I go back. Same medicine they give. I say, why? You're supposed to help me. They say, oh, you go to hospital. I go 2-3 times. They don't do nothing. Anything big time, anything important, they don't help you. It's small thing only.
All right. Thank you, Johan. Sound familiar, Paul Seegert?
I would say it does, and the shortage of real primary care is a problem, because you have people like this example that show up, and it's like calling a call center where you have a different person answering the phone every time, and there's no continuity of care. And we've really gotten far away from the original intent of primary care, where you'd have a doctor that knew who you are and could follow you through your treatment and help you live a healthy life. I think it's a fair statement to say most Americans don't have access to that now because of the decline in primary care and just the way that whole business has evolved.
We'll pause, and we'll come back with more calls in a moment. Welcome back to the Jim Bohannon Show with our guest Paul Seegert, managing partner with PCS Advisors, and we're talking about the lack of health care, principally in rural areas of the country. Here's Tom in Port Angeles, Washington. Hello.
Hello, Jimbo. I'm generally not a very disciplined individual, but Trump made it a habit when he left his rallies, and he would say to the whole crowd, stay healthy. And he put me on a path by doing that. And in almost 3.5 years, I'm down I'm down 35 pounds, and I feel better, but I'm still not a really disciplined individual. And I just thought I'd throw that out there. Go, Trump! And
I mean, it's great to tell everybody to be more disciplined about caring for yourself. But the fact is that most people are not going to do that. So I guess we could use that as a discussion point. I'm glad to hear that there are people who are calling for us to take better care of ourselves, but I'm not sure that really carries a lot of impact. I'm glad that it did on Tom, but for every Tom, there are probably 100 other people that ignore it entirely. You, Paul, have played an integral role in changing the way businesses manage healthcare, their second largest expense. What exactly did you come up with?
Well, I agree with what you said, that we don't, as a general rule, do a good job of taking care of ourselves, and it drives costs up incredibly in our system. Chronic illness, we spend 85 cents on the dollar in our healthcare system treating chronic illness, most of which could be prevented with adjustments in the way that people live. But our approach hasn't been to rely on that, because I don't have a strong, I don't think you can count on it, as you pointed out. But there is a lot of waste in the system, and that ties into the conversation today about hospitals, especially rural hospitals, being at risk. You have costs of specialty medications. You look at Humira, the most commonly prescribed specialty medication in this country, is up 20% in just a couple of years. And they're
by actual cost of production, cost of production, or because in fact there are a few people with no sense of values other than ripping other people off who found out that you can make a ton of dough by doing just that, ripping other people off. It seems to me that if you had genuine healthcare reform in this country, a lot of people making a ton of money would stop making a ton of money.
Yeah, they would have to wait a little longer before they join the country club, without a doubt.
Well, boo-hoo.
There's so much waste. Yeah, so much waste, unfortunately, in our system. I mean, it's very reasonable and consistent for us to find when our team of analysts looks at a health plan that the cost of drugs in the plan is 2x what it should be.
Well, now you have currently in this country, I guess, an underserved portion of the population, which, as we noted, is older and sicker, and nobody particularly wants to serve them because you don't get rich off of serving them. Assuming that the health of the public is a worthwhile public goal, is that another way of saying that the marketplace is not interested in serving this part of the population?
Yeah, I would say so, mostly because of the payer that's paying for their care, and that payer. Do
we change the method of reimbursement? I mean, what do we change here? I would just assume we not just wrap everything up into one big tidy government program. But if the market
right.
if the market really won't meet the needs of these people, then I don't know what else to do. We can't just march them off into a cornfield someplace and shoot them.
Right. Well, they're already on the government's program mostly, and it puts a real spotlight on the fact that the government is not paying their fair share, and private payers are picking up the slack. And in those rural areas, there's a shortage of private payers to make that whole model work. So I think part of it isn't necessarily that we need to roll everything up into a government program, but those that are in the government program, the government should pay cost plus reasonable profit for those providers to do what they do. It's unreasonable to expect them to do it out of the goodness of their heart.
Cost plus reasonable profit. Well, I like that phrase. All right, more to come. Paul Seegert, our guest. He is managing partner with PCS Advisors, 1-866-50-JIMBO. Back in a moment. Welcome back to the Jim Bohannon Show, 1-866-50-JIMBO, 1-866-505-4626. Our guest is Paul Seegert, managing partner with PCS Advisors, and a man who has spent a considerable amount of time looking at the nation's healthcare system, if you wish to dignify it with the term system. Bob calls in from near Fort Leonard Wood, Missouri. Good evening.
Hi, how are you doing, Jim?
We're fine, thank you.
Good deal, yeah. I was thinking, I got to thinking that a lot of these small-town doctors that you used to see in the past, they can't perform the way they used to here because of the cost of the insurance for malpractice, their overhead costs and all their stuff. They just can't make it here anymore.
Well, there are certainly a lot of expenses involved in being a doctor, Paul Seegert, and obviously the cost of medical school and malpractice insurance would be two of them.
Well, and you do point out, your guest is pointing out a very real trend in our system overall. We could be doing a show tonight on just the loss of primary care and the loss of primary care doctors. We're facing a shortage of up to 55,000 primary care physicians in the next 10 years. And it's because, in part, what he says is true. It's very difficult to be an independent primary care practitioner anymore, and to make a living at it, to make a go at it. And you've seen many that have sold to larger health systems, and this is kind of points to why it might be even tougher in some of these rural areas, because who do you sell to keep the ball rolling? So they end up selling to these primary care systems that oftentimes create rules around how they have to perform their work, and it's really about the patient load that goes up significantly and how they direct those patients into the system that they now are a part of. My son, I have 5 kids, and my older son broke his arm, a 13-year-old. We were away from home. We went to a rural hospital. The doctor, the ER doctor, a very good doctor, but he would only give us a referral for ortho care back at that facility, which of course wasn't sensible. We weren't going to be there anymore. We were only there for a few days. But he said, sorry, I understand it's silly, but the rules require me to refer right here within the system. So they're buying up these primary care doctors in the markets that are big enough to buy them, or they are simply going by the wayside or having to move to more urban areas to survive. And then when they get there, they're kind of the gateway. They're directing traffic into the system that has purchased their business or that they now work for.
1-866-50-JIMBO. By the way, our guest has agreed to stay into the next hour, so we will get to your call. Richard in Park Ridge, Illinois. Good evening.
Hi, good evening. So I'm at the end of the baby boomers, and so I need to have a knee replacement. And my doctor last week ordered a very common test, a Doppler test, to check the flow of blood, I guess, in the leg. And my insurance company basically denied it. And they said that it's going to cost me $4,000 if I want to have that test done before the knee replacement. And I don't know where I go with that. I mean, is it because the insurance companies know the age of approximately who I am, and they're denying certain tests because they don't want to pay for them anymore? I'm just curious why a very common test, and what's his thought on that?
Okay, Paul.
Well, it kind of gets back to our reimbursement conversation that we're having, where you might have a test that's non-invasive, that's considered accepted within the industry, and yet Medicare may have a pattern of denying this. And so the physicians, they have to get this pre-authorization done, or they end up doing these things and not getting reimbursed at all. So they, on the one hand, they might get reimbursed not enough, and on the other hand, they might not get reimbursed at all. And if they see that happening, then you're going to, unfortunately, you can be left in that position that you're in today. Now, you may be able to go through an appeals process, and that would require, the doctor's office that you're going to can make the case, so to speak, for why it is medically necessary. And sometimes they are successful with that, but they have to be willing to go through the effort, and it kind of gets back to our conversation prior about how unfortunately overloaded many of them are.
Yeah. All right. We will get to your calls, so stay with us. We'll continue with Paul Seegert in just a few moments right here. I'm Jim Bohannon, and we do come to you weeknights here at Westwood One. Hi there, and good evening. Welcome to the Jim Bohannon Show from Westwood One Radio. We're at 1-866-50-JIMBO, 1-866-505-4626. Online, find us at JimBohannonShow.com. You can follow me on Twitter at Jimbo Talks. We've been talking with Paul Seegert, managing partner with the PCS Advisors, financial consulting firm. And we started out looking at a shutdown of hospitals in rural areas. We have now moved into a general overview of inadequate health care in many parts of our society. Here's a call from Lance in Las Vegas. Good evening.
Yes.
And what's on your mind tonight, Lance?
I'm a disabled veteran, and believe it or not, I had a skin skin problem, and the VA here in Las Vegas doesn't have a dermatologist, so they contracted out to TRICARE civilian, and I went to that dermatologist, and he prescribed a tube of skin cream, and everyone thought that VA here wouldn't have it. And my caregiver went to Walgreens, and guess what? Walgreens charged me for a tube of skin cream.
I'll bite. How much?
$216.99, and I'm trying to collect it. I think Walgreens should take care of something like that, but the information I have is that Walgreens has an exchange program with the VA, and the VA is supposed to reimburse anybody else, but I'm having difficulty collecting $216.99.
All right, well, let's let our guest address that. There are two questions here. One is, how does Lance get reimbursed? And two, how come the law doesn't come down on profiteering parasites like this? That cream didn't cost $299.
No, almost certainly it did not, and likely it was so far less than that it would shock you.
Yeah, well, it wouldn't shock me. I'm afraid I'm beyond being shocked. What shocks me is that no one's done anything about it.
Right. And I would encourage you to do two things. One is you have to reach out to the VA and get an advocate to help navigate this through the system. That, unfortunately, may not be a fast process. And then the other would be to consider looking at other options. If you need to continue to source that cream, download GoodRx or go online and look at GoodRx. Go to Mark Cuban's Cost Plus Drugs. There are some other cash pharmacies out there that don't take insurance. And as crazy as this sounds, if a pharmacy does not take insurance, they are then able to charge cost plus a reasonable profit versus having a cash price dictated to them by an insurance company or a pharmacy benefit manager. And when they do dictate it to them, they elevate it significantly to make their price look like a discount. So it may be, too, that you can find a cash pharmacy where you could have that delivered. And I've seen that the difference in cost can be so significant. It's hard to believe it for folks that haven't seen it.
There are a lot of mobster kinds of practices. There are lots of mobster kind of practices underway here. I mean, any politician who took on these people would pick up votes. I mean, this is not acceptable. This is. Really I mean, people talk about, but they give a lot of campaign cash. There are some things that transcend campaign cash. If I'm a politician and somebody offers me tons of money, all I have to do is publicly acknowledge and join the Nazi party. I'll tell them to go to hell. I mean, I'm sorry, but supporting this kind of thing, there's no amount of campaign contributions that makes this worthwhile. Anyway, Norm in Kent, Ohio, for Paul Seegert. Good evening, Norm.
Supporting this kind of thing, there's no amount of campaign contributions.
I have to ask you a question, Norm. Are you in some kind of speakerphone or something?
I'm going to turn just a minute there. Now, is this better?
Not particularly, but let's try one more time.
Okay, now I'm off the speakerphone. Is this better?
That's better, yes. Thank you. Go ahead.
Okay, very good. Thank you. Are you ready?
Yes, we're ready. We were ready in the beginning. Go ahead.
Okay, and I got a real quick question for you, and just a little bit off topic, but not really. This time of the year, we see all these commercials about this supplemental plans of Medicare, and is that something I should look into? Those for real, because they offer free dental and free eye and all that.
I'm not sure that the actual treatments are free, but Paul, do you need any more information from Norm?
I think you can look into them for sure. It depends on your geography, and it can kind of tie into this conversation we're having about the disparity between rural healthcare versus urban healthcare. You're probably talking about Medicare Advantage plans, which can be more prevalent. It's kind of like an HMO version of your Medicare supplements, and it can be more prevalent or more accessible in areas that have more healthcare providers. So it may be that you see the commercial in your market, and depending on how big your market is, it may or may not be available, but it's certainly worth checking out.
So the short answer is maybe, Norm. Good luck to you, sir. Good luck to you as we go to Chuck in Greenwood, South Carolina. Good evening. All right, Laurie in Colchester, Vermont. Good evening. Do we have Laurie in Colchester, Vermont?
Yes, you do.
Very
Hello,
good. You're on the radio. What's on your mind?
On my mind is the fact that a few different things within the healthcare system. I do have a primary care, and I do preventative medicine, regular checkups with her. And what happens is, when you go in, you can only have 10 or 15 minutes. It's allotted time, and you go in with prepared questions, and what happens often is you can't have those questions answered. So
when you say you can't have them answered, what do you mean by that? I mean,
time-wise.
Time-wise, right?
You go
Okay,
in,
go
you get
ahead.
your blood pressure taken, your regular vital signs and whatnot.
Right.
But say you have an ear infection. The nurse will say ahead of time, what do you have for questions? Because I go prepared with questions.
Right.
And she'll say, well, we really don't have time for that today. And I'm like, excuse me?
May I assume, Laurie, that there isn't a lot of choice in terms of primary care physicians in your area? Because back in the days of yore, that would have been my cue to say you could take your medical service and you could shove it. But I'm wondering, is this doctor it? Is it her or nobody at all? I mean, that's hardly an adequate form of medical care, but do you have any choices?
We have limited choices because I don't want to be tied up with a primary care that's tied within the medical health system here, i.e. the large medical center. So in order to get out of a primary care that's not tied in with the large teaching hospital, you're then limited to the number of primary cares available. So often, in between your checkups every 3 months, say I have an issue come up, an earache or something like that. I don't go to an emergency room, but that's when you use a primary care physician. You go into not a primary care, you go into a immediate care. And they're a step between your primary care and the emergency room. So they might handle strep throat, sprained wrist. You might need a stitch or two, but nothing emergency-wise.
At least you found an emergency room that limits themselves to emergencies. Paul Seegert, do you think that Laurie can do better?
Well, she's dealing with something that is pretty widespread. These primary care doctors that are independent, the reimbursement rates they're getting are so low that they have to see a really high volume of patients to make that business model continue to be possible. So they're just not in a position to provide the same quality of attention and care that you would have grown up with, let's say. So it may be that it could be that you get better care going into that bigger system. I understand your hesitation with that. In my comments earlier, I think I identified some of the misaligned incentives that can exist within that model where they're kind of forced to refer you within their own system for all care and so on. But
yeah,
it's a tough one, and it doesn't have an easy answer right now.
Yeah. Good luck, Laurie. And I'm afraid that's the best I can offer you. Will in Austin, Texas. Good evening.
This subject got my fur up. I got hurt in Afghanistan, Bagram Airfield, July 10th, 2006, as a contractor, and I woke up in Ramstein, Germany, and they repaired my tibia, plateau, and my teeth, and my gallbladder went out. So Aetna insurance paid for all this, and 3 weeks later, I got back into Sherman, Texas, and my bile duct got infected. So my wife drove me to the hospital, and they ran a tube down my throat and charged me another $25,000. And Aetna Insurance said, well, your gallbladder and your bile duct is the same event. However, we're going to charge you another $4,000 deductible. So now I'm in $8,000 deductible, and I'm protesting. This is not right.
Okay, I understand. Well, you're certainly protesting now. Do they have an appeals process with these insurance companies? I mean, how are you protesting, Will?
I'm getting to this. This is good. So I read everything, and these like 7 or 8 doctors got $175 each that reviewed photos of my abdomen, X-rays of my abdomen, and they're charging $175 a piece. Talking to the Aetna people, and I'm bringing this up, and they say, well, we're just going to go ahead and pay that. We don't care. And I said, and this is my point, then I don't care about paying another $4,000 deductible. And the Aetna lady said, okay, fine. So since Barry Soetoro took over the insurance industry and destroyed the insurance industry, it's just a cash cow. And I appreciate what your guest is saying, and I appreciate what you're saying.
Okay. Anything you want to add quickly, Paul?
Well, yeah, we put these insurance companies in a cost-plus model with no max, essentially. This medical loss ratio rule that came in 12 years ago with the Affordable Care Act, so long as they spend 80 or 85 cents for every dollar they take in premium on a claim, they can keep the balance. They actually don't care if 8 people reviewed that and charged $175 each because they're on a fixed markup on all this service, unfortunately. And it has led to some very unfortunate outcomes in our system.
So it would seem. More to come. Back in just a Welcome back to the Jim Bohannon Show at 1-866-50-JIMBO, 1-866-505-4626. John in Livermore, California. Good evening.
Good evening, Jimbo. I have a question for your guest, and I'm just going to run something by you real quick because I'm a little shocked at the guy that had to pay the $300 for the cream, and now he's got a procedure to get reimbursed. But the question is for your guest. I'm a real estate broker. We had a veteran, an Iraqi war veteran, that was being really mistreated by a lending institution and attempting to purchase a home. And when we got the details, I had the agent call his United States congressman. And within 48 hours, the bank was on the phone apologizing. There must have been a big misunderstanding. And I've had that situation similar occur twice with the same result. And I was wondering, do any of these, like the guy that paid $300 for cream, if he called his United States congressman, they would just blow him off, or would they do something?
Well, I guess it depends on whether your congressman has a lot of clout. I don't know, Paul?
Well, I don't know either, but I think if you're in that position, it's leave no stone unturned. It's pretty notorious that there's long lines and unfortunate bureaucratic inefficiency in that organization.
Yeah. Again, different members of Congress. Everybody has a member of Congress and 2 senators, but that doesn't mean they all come with equal shares of influence on Capitol Hill. If you chair a major appropriations committee, well, you may be fortunate and have greater influence. Peter in Lansing, Iowa. Good evening.
Good evening. As I've seen it, the nuns are completely out of the hospitals for some time.
The who are?
The nuns.
Nuns?
The religious.
Yeah, okay. All right. Okay, fine. Okay.
And they're not in the schools for that matter. So as I see it, the mission...
Well, they are in some schools.
Okay. But so I feel the market should just go through a correction and kind of...
Are you suggesting that some order of nuns step in and take over health care? I mean, I'm not sure what you're suggesting, Peter.
Well, I don't think it's a mission, and I think that if the market were to correct itself, the aftermath would be a different healthcare system.
Well, you say the market were to correct itself. I mean, all right, that's something for our guest to talk about. Can the market correct itself, Paul?
Well, it's a very powerful industrial complex, this whole payment model that we have. So there are people trying very hard to change it. I would put myself in that group. And it's a growing number, and there's a growing number of employers that are standing up and demanding change. And able to get it. They do tend to have to be a little bit bigger employer to have much of a voice. But there are some positive things happening. It's just unfortunately a slow process. But the market is, I think there are some bright spots there.
Well, one can certainly hope so. People who are making out like bandits in violation of the market, they're certainly not going to change things because they don't care. All right, we have one more caller who would like to talk to you, and then we'll let you go after this break, okay?
Thank you.
All right, thanks, Paul Seegert. More to come. Welcome back to the Jim Bohannon Show. Paul Seegert, managing partner with TCS Advisors, is our guest. Here's Robert in Newcastle, Pennsylvania. Good evening.
Yes, this is a nurse. County morgue, you stab them, we slab them.
Hilarious. Okay. Is this anything besides the Henny Youngman one-liner night, or did you have something else to mention, Robert? Oh, they hung up. Oh, how clever. Yes, indeed. You must be the hit of all the American Legion beer parties. John in Lansing, Michigan. Hello.
I'm calling about the discussion primarily on the VA health system. What I tell you is I'm very familiar with the offerings, and they seem to be, at least at this time in space, very concerned about the way the VA hospitals look. In other words, brick and mortar. They're dumping tons of money into that. And I'd like to alert you, since your talk was largely the healthcare proper, there's an article in the Stars and Stripes just a few days ago, as a matter of fact.
Which is a military newspaper for those who don't know. Go ahead.
Yes, sir. I know you know what that is.
Yeah, but the audience doesn't, since the vast majority of our audience has never served in the military. Okay, go ahead.
Appreciate that. Yeah, I was in I Corps in '63 under Kennedy. Anyway, the article tells us that they've been trying to implement a system which started off at $10 billion. This is the record system, which ties in directly with the cost element as well as the actual health care. And the two are, you can't separate the two. Well, it started off with a bid of $10 billion. 2 years ago.
Well, what year was that, John? Do you know?
Yeah, 2020. 2 years ago.
Oh, 2 years ago. Okay, go ahead.
Yeah, that was the original bid. That's when they wrote the contract. Okay. And currently, they have only been able to test it in 5 of the 166 installations that they refer to. This is all in the Stars and Stripes article.
Okay, all right. And, well, since we don't have that in front of us, go ahead, and then our guest will respond to you.
Well, the ultimate cost is going to be, according to their estimates now, $50 billion, and they can't get the thing to work after trying for 2 years in 5 locations. And the bottom line is they've already determined that this system that they're trying to get to work for an ultimate cost of $50 billion has already done damage to about 150 people. And,
well, they can't pay for it, and it doesn't seem to be helping people. Paul Seegert, sounds like that's a program to be abandoned.
Yeah, the VA has paused the rollout of that electronic health record project because your guest shared a pretty accurate accounting of the events. They've spent a lot of money and have gotten very little, and have paused it or pushed out the go-live date to March of 2023, I think, instead of something sooner.
Yeah. A lot of fumbling in the dark. All right. Thank you very much for trying to explain the inexplicable. Much appreciated. Paul, thank you.
Thank you for having me.